It's 2:01, so I do want to respect everybody's time and get us started right on time today. I know there may be some additional people coming in. Welcome to those of you who are in so far, and I really want to thank you for taking the time to come to the live presentation on today, which I do know is a fall break day. So we're really happy that those of you who are here were able to make it here. And also, we know that you will be able to share this information with your team, any members of your team who aren't here. And we will also, of course, be recording and have the recording available next week in the OneDrive. So today, on this session, I have the great pleasure of welcoming Dr. Mohamed Hagahmed. He is an emergency medicine specialist here in Pittsburgh. We're very fortunate to have him with us here today. He was just recently named in 2020. He was named one of the 25 under 45 influencers in emergency medicine. So he is up to date and a mover and shaker in this field, which is the sort of the content that we need to focus on this week. He works at UPMC, where he is the associate medical director for the Center for Emergency Medicine, and he's the director of the EMS. So welcome, Dr. Hagahmed. We look forward to hearing what you have to share with us today.
Oh, thank you so much, Dr. Salter. And I really appreciate everybody else who's showing up on this beautiful autumn day. Hopefully it's not raining where you are and trying to enjoy a little bit of a day off. So thank you again for inviting me. First of all, I'm really just honored to be here because this is like one of my, I would say aspirations and goals in life, to be involved with global health. I'm originally from Sudan in East Africa, and I grew up in a couple of countries before moving to the United States when I was, I think, my early 20s. And my ultimate goal in life is to be able to do the things that you are doing now, going back to East Africa and be involved with starting the strong pre-hospital system, specifically in my country in Sudan, and also other countries in the Eastern African region. So it's a pleasure to be here. I know there's not a lot of you. Initially, I designed a poll kind of for everybody, but since it's already not that many of you here, by show of hands, and I appreciate you showing me the camera, anybody here is involved or has experience with EMS at all? Or any certification, EMT basic, or anything like that? I don't see any hands. Okay, I just would like to get to know my crowd first. So do you mind if I share my screen?
Absolutely, yeah.
Can you all see this? Oh, I see a hand. Is that Olivia Lee? Olivia, I guess, had some experience with EMS. Olivia, do you mind just sharing with us? What did you do?
Oh, actually, can you see me?
Yeah. Where are you at?
Okay.
I can see you.
Okay. Oh, hi. My name is Hansel, or you can just call me Olivia. I was EMT in Korea. I worked at emergency room at the hospital. I know that field is not about EMS because EMS is just out of hospital services, but I was an EMT, so that was sometimes I feel really good, to provide first aid to people, but it's really hard to interview patients or take any responsibilities. So I really want to learn about something really interesting thing about EMS and global health. So I'm really looking for today's lecture. Thank you.
No, thank you so much for sharing the experience. Yeah, as we will touch upon here, EMS is different in so many places in the country. So of course, I'm interested in hearing more about your experience in some other location. But thank you, Olivia, for sharing. So here's everybody's favorite picture, ambulance, right? We all love ambulances. No, nobody loves ambulances, right? Because that means badness. Everybody goes to the hospital, everybody's miserable and sick. But for a lot of people, the ones that you're going to be interacting with is actually a symbol of hope. So it means that someone will come and take care of me. So my aims of this discussion today is to give, since all of you don't have, or most of you don't have experience with EMS, to give you an idea about what EMS is, and bear in mind, my perspective is going to be based on the Western perspective. So it's going to be the American design of EMS. And the reason why I'm bringing this up, because I want you to appreciate the time, effort, and dedication that it took for the US system and the Northern American system to evolve over these years, because you're going to be designing, a system in a different country, in a foreign territory for most of you. So with that in mind, I want to let you know that EMS stands for Emergency Medical Services. And a lot of people don't really exactly know what they do. They usually associate it with like transporting patients, right? Like just like sending people from where they were injured or ill to the hospital. The evolution actually started way long time ago in the 1400s. And does anybody can guess, like, I mean, you can throw just some guesses or, hints. Do you know who started EMS or the idea of transporting sick people?
The military?
Not the good. Who said that? Is that Jorge Antonio, right? Nice.
Yes.
I'm glad you're here, buddy. No, it's actually funeral homes. So funeral home directors started the idea of transporting patients. And most of it is actually economically driven. Think about it. Like if I send somebody to the hospital, my hope as a funeral home director is that they're going to die so I can have the business, right? This is like, just think about it like from an economical drive. So these funeral home directors actually were able to say, hey, let's take you, sick person, to a place where they can take care of you. And maybe I can get the business if they know me that I'm a funeral director, and maybe I can just bury you later. I know that sounds very grim and negative, but that was the origin of EMS. And from there, it evolved over the years from just simple transport to, hey, let me transport you, also treat you. Okay. And that's like over the 1800s and the early 1900s. And then EMS started to kind of like, get to the shape that we see now in the like early 1900s, so 1920s and 1930s. In the 1940s, and this is in the US, EMS turned over into fire and police. And I can tell you the reason for this, and this is something that you will also encounter in your country, is that they were having trouble training people to become trained in providing medical care. So what did they do? So they took advantage of police officers, right? They took advantage of fire department, readily available in the community to take care of these folks instead of training people and investing time and money. Now, Antonio mentioned this, which is literally like in the World War II season, when that hit, that's when EMS like started to get the respect that it's getting now, which is basically not only transporting you, but also treating you where you are, because now we know that if you bleed to death, you're not going to live for 5-10 minutes, right? We're going to have to take care of the bleeding right there, so that we can later transport you safely to a definitive care. And then this whole idea of MASH, I don't know if anybody was watching TV, MASH, the MASH units is the mobile army surgical hospitals, became kind of like a thing in the military. And these are like basically tents that act like hospitals and treat people there by EMS clinicians or providers. And then it got better and better throughout the 1950s and the 1960s. The 1950s, the mouth-to-mouth resuscitation, I'm sure this is everybody's favorite, right? I mean, I'm sure you would do this, right? To every patient, no? The mouth-to-mouth resuscitation became kind of like a thing now. Like if I can provide artificial ventilation, I'm able to save that person's life. MICU and the idea of the ICU started to develop later in the 1900s or 1960s, 1970s. And that's where we're starting to see more people sending people from the field to an ICU unit where they can hopefully recover from their underlying injury. The white paper, it's a very important paper that was released in 1965. And what it did, it highlighted the flaws in EMS. It basically showed the gaps in care, showed the gaps in training. That is the lack of uniform laws and standards throughout the country, and even from like city to city variations. And that white paper like emphasized the need, like, hey, we need to do something about this. We need to make this kind of a standard thing so that every patient, every human being, whether it's in Pittsburgh or Philadelphia or New York City, can get the same care. And that's what initiated kind of the scope of practice of EMS. And this highlighted also the need for training, right? I mean, you just can't just put, Antonio on the street. I'm sure I know Antonio, you're EMT, but you can't put just somebody with no training and expect them to save a life, or Isabella or Bethany. You need to go through a specific type of training so that you can have the same quality, or you can provide the same quality of care, just like Isabella from Philadelphia, or just like Bethany down in Alabama somewhere. You know what I mean? Just kind of the whole idea of unified care. That way there will be, like, if there's negligence in care, we know it's a systemic problem. It's not just an individualistic problem as well. And then 911 created in 1968, and then in later in 1969, 1970s, that's when you see the development of a paramedic education. Interestingly enough, emergency medicine as a specialty, as a medical specialty, actually was around the 1960s, 1970s. So you see here, 1969 and 1970, you have now the development of curriculum, paramedic curriculum and EMS curriculum around the same time when emergency medicine became a specialty. So you can see that this is like kind of a inseparable bond between the two of them. NREMT stands for National Registry EMT. So this is the national guidelines that provide the training and the education criteria to each state. And everybody who becomes a paramedic, they take a test, and we'll talk about education here shortly. They take a test to become a nationally registered paramedic or EMT. And we'll go over about these things too. So certification and licensure, why do you have to worry about this as a global health advocate and scientist? Because you need to ensure that whoever people you're going to be training to become EMS clinicians, you need to provide them with the educational, qualification. This is going to be a certification or licensure. So in the United States, everybody who passes a test after they finish their education, they get certified. So that they take the test, they get certified in, let's say, EMT basic or EMT paramedic. And then from there, they take another test to become nationally registered. So I'll talk exactly about like what does that mean? What is the difference between being certified and being nationally registered here shortly. All right, so EMS as a system, it's a very complicated system. It involves many moving players, from dispatch to first responders to fire to EMS. So when you think of EMS, don't think of EMS just as only paramedics or EMTs. It's a broader system than that. And it involves people that are trained at a very basic level, or people that are trained to even make phone calls and arrange folks to go to certain destinations, okay? So you have a federal, state, and local, legislations that actually control that. So we talked about this certification and the licensure. And for example, for myself, I'll give you an example. So I am a state medical director. With my state license, I cannot practice paramedicine, let's say in Texas, unless I am licensed by the federal government. So it'd be like a national registry or something like that. Then I can go and practice in Texas. The crucial and the unit of the EMS system is dispatch. And this is going to be actually one of the cornerstone of the entire system. Because if you don't have people they'll look like this. They're sitting behind computer. Obviously, we have now more advanced computers than these ones, old computers. But they have to get the call. So they receive the call. They try to provide instructions either over the phone or over the radio on how to manage that emergency so they can take care of that patient emergently, like give them instructions on how to control the bleeding, for example. Like, hey, sir, ma'am, apply pressure on that bleeding area, okay? And I'm gonna dispatch EMS for you. So they look at where the phone call is coming from, and then they either arrange for police, fire, or EMS, depending on the nature of the call. Is this like, is this an injury? Is this something medical? Is it something legal or mental or, or fire, related stuff like that? So some locations in this country here, they can train their own emergency medical dispatchers, or you have also like kind of a national oversight on their training as well. But let's say in Guyana, if you want to train dispatchers, you have to be aware of the limitations of the dispatch system in that country. So we'll talk about those challenges here later. In the US, the most common problem is actually language disparities, right? I mean, if you speak, let's say, Urdu or Arabic, they have to get an interpreter, for example, through a dispatch system. And sometimes, I'll be full honest with you, like I've never heard or seen dispatcher using other interpreters, which is very difficult. I mean, when you go down to Texas, they obviously speak Spanish and they have interpreters in Spanish, but in other languages, this is where the disparity lies actually here. Now in Guyana, it might be a different problem. EMR, it used to be called first responders or emergency medicine responders. And these are folks that are trained at a very basic level. Their main role is to extricate people and stabilize them. So let's say someone that is in a fire area or a fire structure or collapse structure, or maybe a turn of a vehicle, they're stuck in there. So their role is to get them out of that, unstable environment, stabilize them while waiting for more like definitive care. So think about the kind of training you're going to provide to these folks is going to be very, very basic training. Okay, so mostly technical stuff and controlled hemorrhage, stabilizing like C-spine or cervical spine. So it's going to be very basic training. EMTIs, now they're called advanced EMTs. So advanced EMTs, they're kind of leveled in between an emergency medical technician basic, so EMT basic, and a paramedic. So in between. And this is something that developed like in 1985, and then went a revision in 1999. So if you ask me why there is an advanced EMT, I would tell you shortage of folks who become paramedics. Okay, so now the country is realizing the need to provide more people who are capable of providing care. However, they cannot train enough paramedics to take care of these people. So think about the cost of training, think about the people that you would like to train to become paramedics. And if you don't have those resources, you have to think of a different plan, which in this case could be maybe developing a plan depending on your geographic needs or political needs or medical needs, maybe somebody to be in between. So I'll tell you the difference, for example, between an EMT or advanced EMT and a paramedic. So an advanced EMT can start an IV. So an IV, it's like an access through the vein to give medications or something like that. However, they cannot give medications. Okay, so they can start it, but they cannot give medications unless they have a direct physician order or the physician is with them, or they have a paramedic with them. Okay. The other thing, they can also assist with medication. So they can do like give somebody like an EpiPen. They have your EpiPen with you. They are recognizing the patient is having anaphylaxis. They can assist them in giving them the medication and also giving them IM medication through the muscle, so intramuscularly, okay? However, they cannot give certain medications and they cannot do a lot of the invasive procedures that paramedics do. We'll talk about these procedures shortly. So paramedic is basically the like highest standard of care in the pre-hospital setting. So paramedicine is an education that involves very extensive knowledge of pathophysiology, pharmacology, electrophysiology, cardiology, respiratory system, all this stuff, okay? So to become paramedic, you need to have an education of minimum, 2 years. That's going to include like in-class education and rotation in the hospital. So it's going to be like shadowing people, doing things within the hospital itself, either the ER, the OR, and then doing these hours and then taking an exam at the end. An advanced EMT, they take a class which is anywhere between 6 months to a year, and then they do a little bit of a minimum of a rotation, but then they take a test. So they don't do that extensive amount of like clinical exposure that paramedics do. So they don't need that much. Paramedics and advanced EMTs, all these people operate, they have to operate under a physician. So you can be like a medical director. And almost all medical directors in the US are emergency medicine physicians. And to maintain the certification and license, you have to maintain certain number of like CME or continuing education throughout the year. So every year, anywhere between like 38 to 40 credits, you have to go over a skill review. Like for example, like me next month, I'm going to do a skill review with one of my EMS services agencies. I'll go there. I see them practice like invasive procedures, like airway intubation, EKG interpretation, all these things, and I have to sign on their skill. Okay, so this is something done every year, but they also have to continue with their education almost like on a regular basis. When it comes to the EMT basic or just EMT, their education is anywhere between 3 to 4 months, depending on where you go. So EMT basic or EMTs, minimal knowledge of like pathophysiology, and most of it is supportive care. So if you think of EMT basic, it's kind of a level above the emergency medicine responder. So EMR, they just do stabilization. EMT, they do stabilization. Additionally, they can provide some oxygen, stabilization. They can actually deliver babies if the delivery is not complicated or it does not, it's not like a breech delivery or nothing like that. So for Pennsylvania, the state requirement for paramedic education is up to 1,500 hours. And that's going to come up to about, usually 2 years of education. So I teach at the Center of Emergency Medicine, and our paramedics, take, 2 years to finish everything, including the clinical rotations and everything else before taking the test. So this is what I do most of my time. I do continuing medical education with my EMS agency. So I have 3 EMS agencies here in Pittsburgh, and we kind of like meet regularly and we go over their calls. We go over certain situations where maybe it was a difficult call, or maybe it was a misdiagnosis, or maybe it was a bad outcome. And we go over like what happened there and how to prevent this from happening again. For medical direction, there are 2 types of directions. You have the online direction and the offline direction. So when I was training in emergency medicine, part of my rotation is to be out there with the city of Pittsburgh EMS. So we have like a kind of, we call it the Jeep, but it's like a small SUV. And this SUV has like advanced medical supplies for us as physicians. So let's say the paramedic, for example, needs me for a difficult patient that needs to be intubated or needs like an airway, definitive airway. So they call the doctor responds. So I'll respond with my bag and has, additional drugs that they don't use to paralyze the patient or sedate the patient and intubate the patient on the scene with them. So I'm physically there with them, helping them take care of the patient. That's online medical direction. So you can see in your country, this might be difficult, right? I mean, you can't have a lot of physicians being there out there unless you have somebody from your local community who is able to work with EMS to provide care to that local community. Now, what most EMS agencies operate on is like the offline medical direction. So offline medical direction is basically protocol, okay? Give you an example. 55-year-old gentleman with chest pain, okay? I am the paramedic responding to the scene for that person. I have a protocol, Pennsylvania protocol, that says chest pain, things that have to do is make sure they get oxygen, they get an EKG, so this is like a tracing of their heart to make sure they don't have a lethal rhythm, and they also get aspirin. So aspirin, if the concern, this is like ACS or acute coronary syndrome, okay? And that's the protocol. So they don't have to call a doctor, they know what to do because the protocol says, if you have somebody with chest pain with risk factors, you do this, this, this. Give oxygen, get an EKG, give them aspirin, give them nitroglycerin if the pain is really bad and their vital signs are stable, take them to the closest hospital that has a cath lab, okay? So that's the offline medical direction. Nobody needs to call me unless they need me. Of course, like I'm always available to them, but if they don't feel the need to call me, they can follow the protocol. Done. Same thing with like somebody with asthma, they know what to do. Somebody with COPD, they know what to do. So that's offline medical education. Does anybody get these two differences? Okay. So be mindful of the time. Perfect. That's what I was hoping for. So it's around 2:28. This is going to be the interactive part of the discussion. What I was hoping to do is give you an overview of what EMS is like. Obviously, EMS, I can sit here and talk for maybe days about EMS, but this is the general overview. Now, what I want you to envision, the challenges that you're all going to be facing, taking care of people in the country you are assigned to. Okay, so let's talk about Guyana for a little bit. So this is the part now we have to have a discussion. So what do you think some of the challenges you are currently facing, you will face with establishing an EMS system in Guyana? Knowing this background that you know about EMS.
I think the first thing would be folks who have the skill set to train and the language ability and the cultural competence to do so.
So you're looking at staffing, which is, it's a big problem in America. Imagine it's in Guyana, right? Staffing is a huge problem. I can tell you from experience here, we are losing a lot of paramedics. This is in Pittsburgh, guys. Like we're losing tons of paramedics. We're now relying mostly on EMTs and advanced EMTs. So the care that people will get is going to be limited to the staffing and the training you provide. Absolutely, I agree with you, Antonio, completely. What do you think some of the solutions that can complement that or maybe work around this issue?
Okay. I would think that maybe, there's Doctors Without Borders, and I know that currently the U.S. is having issues with placing residents. Maybe it would be more of they give an incentive to go to like Guyana or other rural countries to help before going back and matching with someplace. Maybe like that type of incentive during this time.
So let me get it right. Please tell me your name again. What's your name?
Induzi.
Induzi?
Yeah.
Got it. Oh man, I got it the first time too. I'm so proud of myself. Thank you. So Induzi, so you think do you think you're going to be involving like people from the local community initially, or are you going to be sending people, let's say, from a different country to train them? What would be your strategy?
Well, I was thinking maybe different countries. I know that it will be a little difficult, especially with, we have to use part of like the budget to provide traveling and whatnot and housing. But maybe if there is a program that can help with that, with, you know, different countries coming in, and then they would also provide the trainings for the people that are local. Maybe in that time, we'd have at least, we'll be able to use local help.
So you clearly saw my next slide. See if I can get it. Read my mind. So these are very bright, handsome, beautiful people from Guyana that were trained. So these are all like EMTs, by the way, trained by folks in Vanderbilt University. So Vanderbilt has a strong EMS program. So they have an EMS fellowship, and they have also a global health fellowship too. So they sent people to, you know, Guyana, and they trained them to become EMTs. So they helped initially with the training part and the recruitment part. So this is definitely a big point. You're right about, you know, taking advantage of programs that we have here, and look around you and find maybe good EMS programs. Vanderbilt is one of them. Pittsburgh has a strong EMS fellowship here, also part of the EM residency. And they spend time, money, of course. You have to think about the budget. So how much you're willing to spend to train people. I mean, what are they wearing? They're wearing uniform, right? You have to think about the uniform expenses. You have to think about equipment, how long your training will be. So this is the first, I think this was one of the first classes that they were able to graduate with the EMS and fire department. So it can be done, but it has to be done from like multiple like stakeholders. Their EMS director is Dr. Bucks. So Dr. Bucks actually helped with the training and the physician oversight. So he's the EMS director. And he actually also helped with getting people from Vanderbilt to come. So he had some of his training also done in Vanderbilt University. So it was part of the whole deal. So I like this idea of like recruiting people from other countries, or maybe even just programs that you can find easily that they have interest in helping other countries, including Guyana, with their EMS system. So you can do that. You might actually not need to spend any money. Because they might have the resources from their own budget, from their own like institutional budget. But then what will be your problem? Your problem will be like to retain these people, right? So yes, they got the training, but how long are you going to retain them for? So I hope that makes sense. Any other challenges?
Continuing education, maybe?
So I like the CME part, but I mean, you're just starting out, right? In this completely foreign territory. I mean, you have to prioritize your tasks and goals. I would say for me, like CME would be like down at the bottom of my priorities, because I really want them first to be able to practice and learn and be out there. And then CME can be down the line, you know, once you have some like sustainability and consistency and you retain your staffing. So think about EMS and think about the geographic challenges of Guyana. What do you think?
Transportation.
Oh my God, right? Oh, you need roads. You need access to people's houses and where they live. You know, if you know some don't live in houses or live other places. So how are you going to be able to manage that? How are you going to be able to handle this? What's going to be your initial priority? think of the geographic location. I mean, I guess you have the hinterland, right? And then you have Georgetown, which is the big capital. I mean, are you going to just focus on the surrounding area of Georgetown? Are you just going to be like, maybe, I'm not supposed to give any answers, but I just wanted to hear your thoughts. How are you going to tackle this? It's going to be a challenge, right?
Hopefully off-road capability, versatile vehicles, whether it be by land, by water, by air.
But what will be your target population? Where are they going to be living at? I mean, are you going to just like, hey, people, we got EMS for everybody, you know? Doesn't matter where you live, we come and get you.
I guess an issue would be, because I know that here in the US, if you don't have like, if the emergency providers can't know your address, they can't see an address or have a way to find your address, there's no way to know if you're even going to be able to get care at a timely manner, which would be useful. So I guess location of places with nearby workers, and then of course also we need to know everyone that lives around the area to get them the care.
So I mean, I like that plan. I really like that plan. I mean, I think defining the territory that you will be serving, because that's going to be based on your what? On your manpower, right? I mean, it's going to be based, if you, let's say, train 20 people as EMTs, there are 20 people that provide BLS or basic life support. So how are you going to, where are you going to strategically place the stations of these 20 people? Are you going to do just like 3 stations of double crew? So 3 stations of 2 each, because each ambulance has to have a driver, right? A driver, and then someone take care of the patient in the back. So you need 2. So how many stations? So 20 by 2 is that like 10 stations? Are you going to focus more on maybe access first instead of quantity? Are you going to maybe do like 4 stations and ensure these 4 stations are constantly like well staffed and prepared? Or are you going to go really big and just be like 10 stations, very separated geographically, but you ensure at least, you know, those communities get the access? So this is the things you have to worry about. Are you going to do like maybe zoning, you know? And the reason why I'm throwing this term out, zoning, because again, in Guyana is like, you have to worry about like, okay, maybe that area is closer to the hospital or to a hospital, you know, that's zone 1 area versus zone 3. It will take them 90 minutes to go to a closest hospital. And that's now going to bring the other issue. Who are you going to put in that zone 3 station, right? Is it going to be a basic like EMT, or is it going to be somebody with advanced skills? Because it will take 90 minutes to the hospital, right? Versus 10, 15 minutes, which you can manage if you have an EMT. So again, I'm just putting all these issues out. I'm trying not to provide solutions, because truthfully, I don't have solutions. This is why we're all here to share our thoughts. But think of these issues as they arise, because I can tell you as an EMS director, it's easier to, like if someone calls me and is like, hey, I have an imminent delivery. And I will ask, okay, what kind of crew are you? Are you 2 paramedics or 1 paramedic, 1 EMT, or are you 2 EMTs? So you 2 EMTs. Okay, 2 EMTs. And how far are you from the hospital? Oh yeah, we're only like 5 minutes. I was like, okay, then transport to the hospital. We'll deliver the baby here. Or, you know, if the baby's obviously crowning, just maybe deliver there in the house instead of, unless it's a complicated delivery. Again, it's I know it's complicated because it involves you knowing some of the medical aspects, you know, and the needs of your own community. And also it involves you knowing the geographic and the resources in that area, like what they have hospital-wise, police, fire, you know. it's I don't envy you guys because you guys are like a very important and difficult task, but I'm also glad that you are thinking through these problems because somebody has to be able to find those solutions.
Do you see any success in having just a one person at a station and using bystanders as extra hands, or somebody needs to drive and that's their only job? Can you recruit a bystander?
So I can tell you driving an emergency vehicle is not easy. There's actually a course for that. It's called EVOC. It's an emergency vehicle operation kind of course. And imagine you in the back, okay, with a critically ill patient and that driver driving like crazy, like a maniac, right? You're trying to put an IV line, you're trying to stabilize, maybe put some oxygen, and that person who maybe has a license, maybe doesn't have a license or whatever, they hit a big giant, bump on the road or get into a car crash. Then instead of having one patient, now you have 3 patients. You know what I mean? So is this?
I'm thinking more of a rural setting where you have like a pickup truck or a Jeep, or you're on a speedboat. As you have one person with the training and using other people, kind of giving them directions, like when bystander CPR, indicating them what to do. You call 911, I'll do this, you do that. Or do you think it's in terms, I'm just thinking of budgeting and those challenges, or do you think it always has to be, it's better off with a 2-man team?
Well, if you ask me, ideally, of course, I say 2-man team, but of course, this is in that kind of setting, you have to be mindful, like, what is a medical problem? I mean, is it something like a knee pain or dislocation or just a extremity injury that all you need to do is just stabilize and transport? Sure. I mean, you don't have to train people to take care of that. I mean, you can train them to stabilize how to splint a muscle or limb. But if something that is really complicated, like involves delivery or involves someone who is having a hard time to breathe, how are you going to manage that? Because your cognition, you have a huge cognitive load taking care of that patients. So you also have to worry about like giving somebody else a direction, which is just going to be difficult, So having that one person is going to be difficult for them to cognitively focus on providing care while giving directions to other people that might not be aware of like the tasks they're doing. Good question, though, Antonio. I like that question. It's very, very important to consider all aspects. What are the challenges?
This is more of a question than a challenge. But I was wondering if you could talk a little bit about, because we talked about the fact that Guyana has a kind of a tough mental health burden and particularly really high suicide rates. And I was just wondering what EMS response to a mental health crisis looks like, just kind of to inform our thinking around that topic.
No, yeah, it's a good question. I can give you the American perspective. So I take care of a lot of patients with mental health and mental, I would call it catastrophes, because they can either present like manic or severely depressed, suicidal, those kind of things. The challenge in the pre-hospital setting for these people is how you're going to stabilize them to the point of transporting them safely to the hospital. Okay, so to the point of doing that. So if you have, let's say here, at least in the US, so if you have a call, so this dispatch says there is a 32-year-old who is having really aggressive behavior, okay, just aggression, okay? So police usually shows up on the scene. They look at the patient, they try to like restrain the patient. The patient is like very combative or cursing, spitting, those kind of things. But you can tell the patient is like actually having a mental problem, like either schizophrenia or psychosis or something like that. So the challenge for EMS is to restrain them safely so that they can transport them safely. In America, most paramedics they carry medications, drugs to help with psychosis or manic depression. So we can give something called like Haldol. They can give like anti-anxiety medication like Versed or Ativan or Valium, those kind of things now they have available to them. So another medication is called ketamine, which is a medication to help with the agitation and the delirium part of it. And again, all these medications, their main purpose is to stabilize the patient, to sedate them enough to transport them safely. Because as you know, Isabella, is that one of the main reasons why people die from mental crisis is the fact that they either have excessive force to restrain them, or they just stop breathing because, you know, now they have so much energy spent on their, you know, their mental illness right now. So if it's going to happen like this in a country that has already challenges with like providing resources, you're going to have to find another way. So another way maybe is either to involve family members to try to like calm them down or talk to them, or maybe a, you know, religious leader. Like, I don't know. When I was reading, they have different religious affiliation, you know, Christianity is there, Hinduism there, and so many other religions. But I mean, maybe involving somebody from that community who has some type of spiritual role to talk to them or calm them down. Obviously, the last resort is to give them medications. And how are you going to do that? You know, it's going to be difficult in terms of the training, based on the training of that individual. So if you have a paramedic that can give medication through the IM, like muscle, through the shoulder, you know, the butt or the thigh, or if you have somebody else to help you, maybe you can just restrain them safely while letting somebody else talk to them and calm them down. I can tell you, so first of all, in America, unfortunately, I mean, a lot of these mental crisis patients, unfortunately, they, because of their mental illness, they also have like polysubstance abuse too. So cocaine on board, methamphetamine on board, alcohol is on board. So maybe in Guyana, maybe they have also you know, large prevalence of alcohol dependence because of their mental burden. So you also have to worry about that too, like how you're going to manage a drunk person who is suicidal and intoxicated at the same time. I'm sorry, I'm adding all these problems. I know it's my fault, but I want you to appreciate at least my side, because you might end up dealing with these issues there, depending on you know, the cultural and the religious context.
Yeah, that's really helpful to at least get some kind of ideas flowing. Thank you.
You're welcome. Good question. Let's see. I'm trying to look at the chat. See, there's a lot of links. Implications for pre-hospital emergency care training. Nice. Helena said that. Oh, wow. This is like really good resources. I feel like I need to read all of them. So yeah, I mean, 50 million is it's a lot of money, but at the same time, you have to deal with a lot of issues. So I guess, you know, your main task is to prioritize, because you want to like come up with a project that is sustainable. You know, you don't want to just be like, hey, let's create an education experience, and then the class dissolve and they stop practicing within a year. Another, I know I hate to add this too. A big issue with EMS is burnout. Okay. In the US, burnout in healthcare in general is very prevalent, but also in the pre-hospital setting, people just quitting left and right because they just cannot deal with the emotional, the physical, the mental drain of that. So think of that as well when you train your staff, is that these staff also, they have families and they have, you know, their own, I would say problems, but their own issues they're dealing with, either at home, either mentally or health-wise or economically, right? I mean, they need the job. So how are you going to pay them? How are you going to support them? Let's say if one of your employees has a mental crisis or an issue with burnout, like how are you going to support that? So also ensuring that you have good retainment of your employees is very important too, because sometimes, EMS, they just work for a year and they're gone, they'll leave, because they're done. They've seen enough, and a lot of them can, handle enough. So you have to be on top of that in order to sustain your agency.
Olivia, do you have a question?
Olivia, you had a question?
Yeah.
Oh,
Yeah, I have a question. Actually,
I'm sorry,
can
I
you hear
missed
me
you.
now?
Yeah, I can hear you.
Okay, I'm sorry, I'm outside. I have a question about is there any challenge about like training? Because when you when they train people, they have to have like requirements about education. Is there any challenges about that? Especially, I mean, related to Guyana?
Yeah. So if you are starting like a brand new curriculum, like let's say like I gave you this example here with Vanderbilt. Let me just fast forward. No, there you go. So what they did in this example is that they basically copied the exact educational design and curriculum in Vanderbilt University. So how they trained EMTs in that, in that institution, they basically copied it and they took it with them to Guyana. So they did the same thing. And from there, they just said, hey, this is our curriculum, and this is how we train our EMTs in Vanderbilt, and this is what's going to be the standard. So in this setting, for example, those EMTs who they trained, if they went to Vanderbilt, they'll be able to practice EMTs there. So it's kind of the same scope of practice, So if you are starting a brand new curriculum, you can do whatever you want. You can do, like, let's say, instead of focusing on something that is not prevalent in Guyana, like, for example, I'm not sure, like, stock example. Let's say if you see that in your population, there is no prevalence of heart failure, for example. So you can design your system as, hey, let's not focus on heart failure because there's not that many people here with heart failure. Let's focus on people that deliver babies. Yes, this is it's more prevalent in our country. So let's focus on this training. But so you can do like whatever you want, but you have to also assess the needs of your own local community so that you can provide the right and appropriate education system for them. You know what I mean?
Yeah, actually, yes, yeah, that's really good point. And yeah, well, I was gonna ask, like, there's nothing, I mean, there's no difficulties when they gather education people who got high education, because for paramedic or EMT, they had to have a high education. So is it, yeah, I was curious about that area because, yeah, you know what I mean?
Yeah, no, I might get it right, but just correct me if I'm wrong. So if you want to become an EMT in the United States, you have to finish high school. That's the most minimum.
Yes. And I just want to know that situation in Guyana. Because do you know something about,
Good question, because I don't know the answer to that. I mean, I don't know. I think it says that the high level of, I think I saw the number of 50% that people there finish high school. I might be mistaken when I read the document, but 50%. So what you can do is you can say, okay, let's say I'm going to announce this job. Okay, I'm going to announce a job of EMT. Let's see how many people are applying. Let's say out of the 10 people, you have 8 people applied, but they have no high school education, for example. Okay, just I'm throwing out there as an example. I know this might be an overstatement. So your problem is like, okay, well, I have 8 people, no high school diploma, for a job that requires minimum a high school degree, right? Like a high school graduation. So what you can do is like, okay, maybe that's what I have available. I'm going to work with what I have. And instead of training them to an EMT basic level, I'm going to train them to become emergency medicine responders. Remember when I told you as EMR, you can train them to do that. So stabilization, extrication, safety, like just very basic stuff. And you can do this within even a month. Okay. And you tell them, hey, I have an incentive for you. If you work for me, okay, if you work for me, I'm going to help you get through high school. How about this? How about this? No, I have even a better thing for you. If you work for me and you promise me you're going to work for 2 years, not only am I going to get you through high school, but I'm going to also give you a job here as an EMT basic. So you have a job with a good income. And then if you want to be a paramedic, how about this? I got 50 million. If you want to be a paramedic, I'm going to make you a paramedic, for example, So just like, I'm throwing it out there. So you can do whatever you want, but at the same time, like, know your resources. If that's what you have, you can always create something bigger because you're genuinely interested in improving that community. And as long as, trust me, like if the people can feel that genuity and people feel your genuine interest in them, they want to also invest their time with you because you're investing your time, your money, you're making them grow, you're making them become something that they want to become. And more, right? So you can do that. That's a really good question. And I hope I gave you a good answer, I hope.
Yeah, really, thank you. Yeah, I can organize my thoughts from your answers. Thank you very much.
Oh, nice. Okay, maybe I'll get a 20% of that 50 million. Oh, bad joke.
I have a question.
Yeah.
For like this teaching program, like would the students have to pay for it, or were you like what would be like the money of like at least like one student? Like what's their like responsibility financially?
Yeah, no. Nicole, right? Nicole?
Yes.
Awesome. Nice to meet you. Yeah, so you can pay for the entire course. So you say, you know what, I'll cover your, let's say if they're not high school students, I'll cover your EMR, like your emergency medicine responder course. If you need, I'll get you through high school. So if you need money for high school, clothes, whatever you need. If you're going to be sponsoring them through the EMT basic class, so make sure you give them a stipend. So that'd be like in addition to covering their tuition. So it'll be something like every month they get something like kind of a stipend to cover their, housing, clothes, rent, food, those kind of things. So I'll give you an example. So at the center, we sponsored students. So students from underserved communities, they would come and we'll encourage them to become paramedics or become EMTs. And we give them a stipend, for example, every month. So we give them just random number, maybe $1,000 every month. Okay, so books, uniform, meals are taken care of. So they get like meal stipend. In addition, they get like $1,000 every month. And that way they have rent covered or bills covered, those kind of things. Is that okay?
Yeah, that makes sense. Thank you.
Yeah, no, you're welcome. It's all good questions. I like how you're tackling that. Oh, wow, it's already 3 o'clock. I can't even imagine. What's this crazy? Time flew by. Anything else? Anything I can help you with or be of any benefit or help you as you organize your thoughts and plans in this noble mission?
Yes, I have a question. I think a little bit ago we talked about like there are ships that also provide medical attention from other countries. What, I don't know, like thinking of its expenses and how much they might cost, would it be, are those more expensive and less sustainable? And then also like maybe we have helicopter service. I don't know. I'm trying to see like what would be beneficial about like large medical ships.
You mean like different organizations helping you?
Yeah, kind of like a global effort. Like, let's say there are nearby coastal areas that have those types of like Navy ships. Maybe if they're not really using it that often, or I don't really know the price of a Navy ship, but I'm assuming it's going to cut into that budget quite a bit.
I have to caution you though, when it comes to these things, because you're getting something that is not top notch, right? I mean, it's not like a brand new equipment. And if you get something that is secondhand, what do you have to worry about? You have to worry about maintenance. You have to worry about fueling. You have to worry about recertification to ensure, because you're putting human beings in that thing, right? You're putting human lives in a helicopter or a boat. If that boat sinks or the helicopter crashes, you have to, now maintain it and repair it, those kind of things. So that's going to be another challenge for you. Certainly, if that's what you have, of course, you work with what you have, but then that's going to involve now you getting a mechanic or hiring a full-time mechanic and hiring an engineer, also hiring a pilot, because you can't train these people to become a pilot. It takes time and hours of flight to hire. So it's the more things you add, which is good because you're making your system bigger, but the more problems. It's kind of the same thing, like the more money, the more problems, right? I mean, the same thing, same concept. But if your focus is, let's say, and again, I keep going back to your goal. If your focus is to serve zone 1 and 2, which is about an hour away from Georgetown, or maybe an hour away from the closest hospital, then maybe you don't need a helicopter. Maybe you just need a couple of trucks, depending on the road situation, depending on barriers, like geographic barriers to get there. You can do, let's say, for the next year, my main focus is to ensure zone 1 and 2 get sustainable and consistent EMS care. That's my goal. That's what I'm going to focus on. That's where my money is at. And then once I, achieve that sustainability for the next, let's say, 5 years. So 5 years, consistent EMS calls, and then you do your studies, right? You do your numbers. So over the next year, there's 15,000 EMS calls. How many of them went bad? How many of them went well? What can we improve? What were the obstacles? And then after you secured zone 1 and 2, then you go further. And then by then, once you provide the data to the stakeholders and you show them, look at this, zone 1 and 2, we decrease mortality rates, we decrease childbirth mortality, we did this. Now I'm ready to expand. I'm ready to do this for zone 4 and 5 or 3. You know what I mean? So instead of like investing your energy on different like fragmented parts, focus on one single goal. That's going to be your yearly goal. That's going to be your budget. And then focus on sustainability of that goal. And then collect the data to show your stakeholders, I don't know, maybe Doctors Without Borders or the other organizations, like, look what I've done. This is the studies. This is what we'll be doing. Look at our mortality rates. Look at all these kids, being born alive and growing up in a healthy environment. This is what we're doing. Can we expand? And then this is even like, it doesn't have to be stakeholders. Even look at your community members. They'll see this. They'll be like, yeah, I want to help. And then instead of like having 10 EMTs or 10 people showing up at your station, now you have 50 people. Like, I want to do this too. Like, look at me. Like, I want to get a job. I want to help my community. I want to save a life. I want to make a living. And then it keeps racking up, and you're I mean, at least that's like my optimistic view of things. Sometimes you'll have to deal with a lot of challenges along the way.
Excuse me, I have a question.
Yes, please.
Are there any recent developments in technology that have, possibly if you're creating a new system, it might kind of jump start old practices that if you were going to invest, you might not invest in okay, I'm going to use this example. A vehicle, you might invest in more cell phone technology or something like that. Is there any type of that students should be considering that, or it's kind of like cutting edge right now with emergency medicine?
Oh yeah, I mean, thank you so much, Elaine, for bringing that up. I mean, telemedicine is huge, right? Telemedicine is a big things right now, at least in the US. So all of you know now we'll live in a pandemic, right? I mean, if you're surprised, we'll live in a pandemic, right? Just making sure you know this. So a lot of COVID patients are contagious. So what we now realize it's some of these patients, they have COVID, they call 911 for some symptoms, but these symptoms are minor. So what we have been doing in some places in the country, even in Pittsburgh here, we've been utilizing the power of telemedicine by using iPads. So iPads with EMS going home, they look at the patient, obviously they're all covered in their PPEs, and then they call a physician, or a physician speaks to the patient, is like, hey, yes, sir, ma'am, you have COVID, your symptoms are minor. You don't have to come to the hospital because the hospital is full. No ICU beds, no ventilators, but you're stable to stay at home. So instead of that transport, instead of getting or occupying a bed, actually EMS is able to arrange for oxygen if they need to at home, for example, or some medications that can help with their symptoms, like antitussive medication for coughing or inhaler therapy. That way they can, help decrease the load on the hospital. So this is another thing you might use. You can use some of the budget to provide telemedicine so that, for example, instead of looking for paramedics, you have EMTs, right? That live in that community, and the EMT can actually directly contact a physician. And then the physician says, you know what, that patient does not need to be coming to the hospital, or I can instruct you to do A, B, and C to take care of that patient as they are waiting for more advanced transport or something like that. So this is another option as well. So that's a really great point. Thank you, Elaine, for bringing it up. That's good, brilliant. Any questions about this or other aspects of IT stuff that I'm not too familiar with?
So I'm going to ask another question. We had Dr. Abdul Wahid, who's new to our School of Public Health, and he has worked a lot on the impact of climate change and health services in the Caribbean. He's actually from Suriname. And the dean of the School of Public Health has just said, there's not going to be, I don't want to generalize, that climate change, we know it's an issue of our time. So do you see kind of climate change? How do you see this intersectionality between emergency medicine and climate change? I'm just throwing this out because I know the students are thinking about it.
Yeah, I mean, if you think about that location specifically, you're going to have to worry about excessive amount of flooding and rain, and even it's going to affect the types of pathologies and diseases you will encounter, right? I mean, if you have somebody who is prone into getting reactive airway disease or asthma, for example, so humidity and heat probably won't do them well. Or, for example, think about other illnesses as vector illnesses like mosquito illnesses in excessive flooding and malaria and other insects that can transmit dengue, West Nile virus, all these other diseases. So absolutely, I mean, it's definitely interconnected. I mean, if you have a country now that is just being flooded with water nonstop, and then you have already a poor underwater system or sewer system, then you're going to have a lot of diseases that you might not see in one region from the other, depending on the location. So you might see maybe here, oh, there's maybe in zone, I'll give you an example. Zone 1, lots of flooding, lots of rain, lots of people that have sepsis from like infectious etiologies or infectious diseases. And then you have zone 3, which is far east and is mostly like heat related, like people that do get like heat exhaustion, or because that in zone 3, most of these folks work in construction more, the construction workers or farmers, or maybe work in the forest. So they don't have maybe enough water supply, so they're exposed to the heat all day long, and they end up passing out. It's called syncopal episode, like passing out. So syncope from heat exhaustion. So now you're going to have to arrange your resources so for zone 1, you're going to have to make sure your staff or people have more access to what? What do you think? Say malaria, West Nile, infectious diseases. What do you think? What do you think about zone 1 supply? What do you want to supply them with? Squeezing you all. So you have high rates of infection in zone 1, and you have high rates of syncope or heat exhaustion on zone 3, because there's more construction, young people in zone 3, and then you have lots of flooding in zone 1 with infection from vector illnesses. So yeah, I mean, it's tough. I know it's medical stuff. I know. So zone 1, and you have to think about this. I know I'm not expecting you to be a medical expert, but you have to think about these resources. So zone 1, you have to worry about like getting IV fluid. You have to worry about getting like antiparasitic medications, like quinine drugs, maybe antiviral medications, maybe even Tylenol for fever, right? Like something like that to help these patients. Now, zone 3, they need what? They need more cooling. So think about ice. So think about the system, the foundation. So you're going to need to have like fridges. Maybe you need to ensure that your trucks now have cooling supply, like maybe cold IV fluids or cold water. You need to ensure that your vehicle have enough like air conditioning in zone 3. Maybe in zone 1, you don't need to have, I don't know. I'm just giving examples, but climate change and population health are very interconnected, and it's going to definitely influence you in how to distribute resources. Good question.
I really appreciate this. This is Cindy. I'm sorry, I'm having a hard time unmuting myself. But I really appreciate that last piece that you brought up, the idea of how important it is to have to be thinking about the needs of the different areas, and to be thinking also about some of those maybe more run-of-the-mill assistance and treatments that people can have available for people that's not as necessarily as high tech. I'm really glad that you brought that up. I think that especially in a low resource situation, is so important to be aware of.
Oh, no, thank you, Dr. Salter. I mean, I just want to give you all a heads up. Do you know the number 1 cause of childhood mortality in a third world country is actually dehydration from like diarrhea or nonstop emesis? So if you have in a zone, you're taking care of it and you're trying to think of the resources, so you have high infectious rate, or because of the climate issues, the climate change, now you have lots of flooding, and that will result in poor sewer system, and that will result in high rates of diarrhea, like infectious diarrhea. You have to be very aggressive, because these kids will die. Like 1 in 2 child in every country that is, plagued with flood infectious illnesses will die from diarrhea or volume loss, or will die from uncontrolled emesis or vomiting. But diarrhea is the number 1 killer in children. So this is a very important point to think about. Thank you so much. I really enjoyed this discussion. I can't really thank you enough for enlightening me.
Well, thank you so much for being here. I wasn't, I've been, as you can see, I'm in my car. I had to drive to my next meeting. So, but I had a great chance to listen to everything. I could never get myself off mute, but this is exactly the sort of information that we really needed to have, I think, to begin thinking about all those different pieces of an emergency medical service system, right? An emergency medical system, going beyond that idea of and how you're going to train people, what the people, different kinds of people that you need. And then also just these most recent questions and comments, just the different tailoring your intervention to the needs of the different regions that you're trying to reach. I think that's exactly the kinds of things we want teams to be thinking about now. So thank you so much for doing this with us.
It's my pleasure. I just had the pleasure of meeting all of you. Maybe hopefully one day I meet you all in person. But I don't envy your job. I'm actually glad you're doing it. This is like such a noble mission you're aiming for, and your population will thank you. You will be helping a lot of people. I mean, honestly, this is why we do what we do. And I wish you all good luck, and maybe hopefully I see you soon in Atlanta and Emory, all of you as champions. Oh, I just want to also share my information too. So there you go, that way you have it. Can you see it? Yeah, so that's my email. I know nobody likes Twitter, but I do Twitter just because of medical stuff. And I know I'm not at Facebook. But if you want to follow me on Twitter, I would love to see your comments there as well. But please email me with any questions, comments, concerns. I really appreciate your feedback too. And I look forward to seeing your accomplishments.
Okay, well, thank you everybody for being here today. I think this was such a worthwhile session. It's just been really critical information, right, for your next steps. And I really do appreciate those of you who were able to be here on this break day. And crucial that you share this information with your other team members. Obviously, we'll have the recording up for them. Elaine, do we have any announcements to close off with here, or are we all set?
Just if you want to inform them about the budget.
Oh, yes, that's right. I put it in the chat, but I wanted you to be sure. We had been in discussion previously about what we should be thinking about in terms of budget. And we're capping the budget at $50 million, 50 million US dollars. So that sort of gives you a ballpark, just some parameters to work within, so that just to guide your thinking, guide your planning for the overall proposal. We'll put a piece in the OneDrive. We'll put it in writing in the OneDrive, so you won't necessarily have to remember it today. But yes, budget capped at 50 million US dollars. Any questions about that?
Dr. Salter, for how long is that? What's the time frame for that?
That's for the startup. The startup and initiation period. I think in the I'm trying to remember now the scope of work. I think they say for the first year, right? So that would be to get you started, and then projecting for the future. I mean, you wouldn't need to necessarily spend it all in the first year, but if your proposal is going out obviously further, oh yeah, I see what you're saying. So you would need to be able to stretch that out. What did we say? I don't have the proposal in front of me. What did we say for you were to initiate and then have a projection, I think, for 3 years. So it would need to be for the whole 3 years. But I'll check on that, and we'll write it up clearly in the scope of work. Okay, we'll make sure that that's clear. That's an excellent question. Like how much the money is for. I don't know if anybody is looking at it. Does anybody have any other questions? Trying to get back over to the chat and see if there's anything in there.
No, there's nothing.
Okay, so we'll put that in the we'll clarify exactly the time frame and for the $50 million, and we'll put that in the OneDrive, and then we'll see you all next week's our week off. No, we'll see you all next week.